Good morning, students. Today, I am going to discuss regarding the factors that modify the effect of the drug. So, individuals differ both in the degree and the characteristic of the response or the effect which is produced by a drug, and variation in the response to the same dose of a drug between different patients and even in the same patient on different occasions can be seen. So, one or more of the following categories of differences among the individuals is responsible for the variation in the drug response. Like individuals differ in the pharmacokinetic handling of the drug. Some different patients, persons, they are having a different pharmacokinetic profile. They have the different enzyme levels. So, the absorption, distribution, metabolism all are going to be affected with the different handling or the pharmacokinetic parameters which is associated with the patient. So there can also be variation in the number and state of the receptor coupling protein or the other components which are involved in the response. So the response at two different occasions can be seen different in the same individual also. There can be variation in the neurogenic or the hormonal tone or concentration of specific constituents like the endogenous substances. They can be varied in different individuals. So these factors modify the drug action either quantitatively or qualitatively. Quantitatively means the plasma concentration or the drug action is increased or decreased, and qualitatively the type of the response is altered, that is drug allergy or idiosyncrasy can be seen with the same amount of the drug at different occasions. So the various factors which are going to modify the drug effect are: first is the body size or the weight. So, if we are giving an adult dose to each and every individual, not all the individuals will have the same weight. Some may be thin, some may be overweight, some may be obese, or some may be underweight also. So, it can influence the concentration of the drug which is attained at the site of action. And the average adult dose refers to the individual of the medium build. So, variation in the patients can be there in their weight, and based on that the per kg body weight dose is more uh, better. So for exceptionally obese or the lean individuals, or for the children, dose may be calculated on the body weight measurements, like individual dose into body weight is equal to the body weight upon the 70, that is the average dose, into the average adult dose, or the individual dose into the that is the body surface area divided by 1.7, that is the, and the body surface calculated using the body weight and the height of the individual. So with this formula we can come to know about the individual dose. Then second is the age. With age there are a lot of variation in the individuals. As I have told, the infants, they are having a larger water content, and with the age, the water content is going to vary. So, if we are going to calculate the infants, they are not exact the miniature of the adults or the smaller form of the adults. They have different types of different pharmacokinetic handling, or their absorption of the drug is different, their metabolism is different, their liver can be immature, the enzymes are less released. So these variations can be there. So we can calculate the dose of a children from that of the adult. Often these formulas are used, Young's formula or the Dilling's formula, where the dose child dose is the age divided by age plus 12 into the adult dose, or age divided by 20 into the adult dose. So these are the formulas. But the infants, as I have told, that the infants and the children are having important physiological differences from the adults. They have higher proportion of water. They have low plasma protein levels. So the more the active drug is available for action, and they have the immature liver or the kidneys. So often the metabolism of the drug is slower, or the excretion is slower in the children. So we should be very cautious while we are giving a drug, and we should not simply see the kids or the children as a miniature of the adults. Even in the elderly also, There are different changes which occur with the aging. There can be renal function declines, the intact nephrons are lost, so the drug dose need to be reduced. They often, the adults, they suffer from chronic different disease conditions like diabetes, hypertension, etc., or cardiac diseases, then arthritis and etc. So they are suffering with a multiple number of diseases, and they are taking n number of drugs for all the individual disease conditions. So we have to be very cautious while prescribing drugs for the elderly. We should always look for the drug interactions. There can be decreased plasma protein binding because with the growing age, the plasma protein concentration decreases. They have a slower metabolism, slower excretion. They have dietary deficiencies. With the aging, the elderly, they are taking lesser of the nutrients, the food. Their appetite is reduced. They often do not eat, so they can lead. These all can lead to dietary deficiencies, and they use the multiple medications, and there is lack of compliance. Often they do have some forgetfulness is there, so they often do forget about the drug which they have to take. So there is lack of the compliance too. Then coming to the third factor which modifies the drug action is the sex of the patient. Females have a smaller body size and so require a dose of the drug on the lower side of the dose range. And they should not be given uterine stimulant during menstruation and quinine during pregnancy or sedatives during lactation, because that is going to affect their child. So females, they are genetically and as well as physically, they are a bit different from the males. So they are having menses. They often have the pregnancy. Then they have to lactate the or feed the kids. So when we are prescribing a drug for a female, we have to be very cautious for and look for these conditions. Otherwise, we are going to land up in some disaster. So pregnancy also, in pregnancy we have to modify a lot number of drugs. There are lot number of physiological profound changes which can affect the drug response also. Like GI motility, it is reduced. So with the reduced GI motility, there is slower absorption of the orally administered drugs. So we have to be very cautious for this. The plasma or the extracellular fluid volume expands, the albumin level is low, the renal blood flow increases markedly, and the hepatic microsomal enzymes induction is there, so they can be failure of drug therapy. So all these things we have to keep in mind while we are prescribing drugs, and these factors do affect the action of the drug. Then drug food interactions. So food can have a lot effect on the absorption, etc., absorption of the drug. The food can delay gastric emptying and delay the further absorption of drugs such as ampicillin. If taken with food, the gastric emptying is delayed, so the absorption will be lesser for such drugs. There can be calcium in the milk which can interfere with the absorption of tetracycline or iron by chelation. And if there is protein malnutrition, so the patient will have lower body weight, reduced hepatic metabolizing capacity, and hyponatremia will be there. More free drug will be there, lesser metabolism of the drug will be there, so the plasma concentration of the drug can increase. Then there are inter-individual variation based on the species and the race. So, like in animals, if you see the rabbits they are resistant to atropine. Rats and mice, they are resistant to digitalis. And in our human beings also, with the variation in the race, the blacks they require higher, and the Mongols they require lower concentration of atropine or ephedrine to dilate their pupil. So these type of variations are there. Genetic variations are also there among two individuals. Then the factor of route of drug administration can also alter the effect of the drug. IV route dose is smaller than the oral dose. We cannot give what amount we are giving orally. If we give IV, then we can have very serious adverse effects also. By different routes, magnesium sulfate has have different effects. Like if we take orally magnesium sulfate, it has purgative effect. Then if we take it parenterally, it has sedative or the hypotensive effect, and locally it reduces the inflammation. So by giving it by different routes, we are going to produce different effects. Then chronopharmacology, that means if we are going to give a drug on the different occasions, it is going to alter the endogenous system in different way. So there are certain time period when which we are going to give the drug, it is going to be more beneficial. Like if we are going to give hypnotics, we have to give it at the night time so as to induce a sleep like condition. Or corticosteroid is taken early in the morning so as to make the person ready to cope up with the hardships of the day. And similarly, statins are given at the night time because maximum synthesis of the cholesterol occurs at the night time. Then psychological state, the effect of the drug can be affected by patient's belief or attitude or expectations. Particularly, these psychological state is very influential for the drugs which are going to act on the central nervous system. And in some patients, even the inert drugs such as the placebo may also produce beneficial effect equivalent to that of the original drug, and may induce sleep even in the insomniac patients. And the other factors which are going to modify the drug action is the presence of disease or the pathological states, where drug may aggravate uh, underlying pathology. The drug can cause renal failure or hepatotoxicity, like isoniazid, the anti-tubercular drug, they causes hepatotoxicity. And hepatic drugs can also produce effect on the or the disease condition can produce effect on the drug metabolism or pharmacokinetics. Like hepatic, if the patient is having hepatic diseases, there will be slower metabolism, microsomal enzymes will be low, and so the metabolism will be altered. In the renal disease, there will be slow eliminations. Then acid base abnormalities can produce uh, changes in the drug absorption or the elimination. And in severe shock, when there is vasoconstriction, there can be delayed absorption of drug when we are going to give it by subcutaneous or intramuscular route. Similarly, drug metabolism can be enhanced in case of hyperthyroidism and diminished in case of hypothyroidism. So, different disease conditions can also alter the drug pharmacokinetics, and even different drugs can produce pathological state. So, these are the important drug effects. So coming to the drug dosing for patients who are having with renal failure patients, we have to give the reduced dose that will be based on the patient creatinine clearance divided by the normal creatinine clearance into the normal dose. For patients with hepatic failure, we have to consider various factors regarding so as to calculate the dose of the drug. Then one very important terminology is cumulation. Any drug which is given at a constant rate will accumulate in the body if the rate of administration is more than the rate of elimination. That means slowly the drug will accumulate in the body, and there will that will lead to accumulation. Example is digitalis or the heavy metals. If we are exposed to heavy metals, slowly the body will accumulate a large amount of heavy metals. Then genetic factors, like there is lack of specific enzymes in individuals. There are lower metabolic rates, like slow acetylators are there. Then there can be plasma cholinesterase deficiencies or the atypical ones. Then G6PD deficiency leading to hemolysis. Then glucuronide conjugation. So so lower metabolic rate can be because of these variations, and genetic factors do have important role on all these types of metabolic pathways. Then coming to the next factor is the tolerance. Tolerance, that means we go on increasing the dose till we reach a ceiling dose, after which if we are going to increase the dose, we are not going to increase the effect. And tolerance can occur by the naturally or acquired, or cross tolerance can be there, and one is tachyphylaxis, which is seen with ephedrine, tyramine, or the nicotine, or the drug resistance. So usually seen this tolerance is seen with alcohol, morphine, barbiturates, or the CNS active drugs. Reverse tolerance is that same amount of drug produces increased pharmacological response. That is reverse tolerance. And cocaine and amphetamine, when given in rats, there is increased motor activity. So that is a case of reverse tolerance. So innate tolerance is genetically lack of sensitivity towards a drug. Like Negroes, they require higher mediatic action of the sympathomimetics is not there. Rabbit are tolerant towards. That means they have inborn or the genetically they are having a lack of sensitivity towards a drug. Then acquired one is there which occurs with the repeated use or dosing of the drug that can be pharmacokinetic tolerance, pharmacodynamic tolerance, or acute tolerance. Pharmacokinetic tolerance, that means repetitive administration of a drug causes decrease their absorption or increase their its own metabolism. As I have told that of carbamazepine or barbiturate, they increase their own metabolism, or alcohol decreases its own absorption. So these are at the pharmacokinetic level, but that the increasing dose is not going to increase the effect. Then the pharmacodynamic tolerance is there is, occurs the downregulation of the receptors or impairment in the signal transaction, which is seen with the morphine, caffeine, or the nicotine. And acute tolerance, that is tachyphylaxis, is the acute development of tolerance after a rapid and repeated administration of a drug in a very short interval of time, such as seen with the ephedrine, tyramine. So tachyphylaxis is actually a type of tolerance which is very acute with the which develops very rapidly and with the repeated administration. Like Monday disease is a type of tachyphylaxis. It what happens? The patient, the persons who are working in certain factories where nitroglycerin was used, on the Monday to the Tuesday, the patient have a headache, and after that they get tolerant. What happened that nitroglycerin they dilate the blood vessels in the brain. So what they do, due to that dilation, there is headache, and after the fumes were taking of nitroglycerin after certain 2 or 3 days, what happened that these they get the receptor they get tolerant towards the nitroglycerin, and slowly that vasodilation is not there, so the patient will get rid of this headache after 2 days. And when they go for the holiday and they come back again, they again develop the headache because the tolerance was gone. So this is one type of tachyphylaxis. Cross tolerance means there is tolerance among drugs belonging to the same category, such as morphine, heroin, or the narcotics. So this is the cross tolerance. That means if a patient is tolerant towards morphine, he is also tolerant towards the heroin or the narcotics. That means these all are narcotic drugs. These are of the same category drugs. So the patient is tolerant towards all of these drugs. So there can be interaction with other drugs also by interacting in many ways. Two drugs can interact by summation, or the synergistic effect is there. They can be antagonistic effect also. And if we see the next part is the stages of the drug development. So if we are going to develop a drug, the synthesis and isolation of a compound takes 1 to 2 years. The preclinical studies, it takes 2 to 4 years. Scrutiny and grant of the permission for clinical trials, it takes 3 to 6 years. The pharmaceutical formulation or the standardization, they take around 1.5 to 1 year. And the clinical studies begin, that is the phase 1, 2, 3, and 4, or the post-marketing surveillance, it takes 3 to 10 years. And review and grant of marketing, zero point 0.5 to 2 years. And then post-marketing surveillance, that is 4 years continues for long period. So how the drug comes to the market? It is lead identification, then lead optimization through various modifying the pharmacokinetic, pharmacodynamic profile, then in vitro or in vivo cell culture technique, animal study of the pharmacokinetic, pharmacodynamics, and the toxicity. And this all data then is done and the patent is applied during this stage. And after this data, we apply for the investigational new drug application. And with this investigational new drug application approval, we come to the clinical trial phase, which is divided in phase 1, phase 2, and phase 3 trial. In the phase 1, it is done in the normal human beings, no patient is there. So it tests the it is the clinical pharmacological trials where human volunteers around 2 to 10 participate. And we get an idea about the pharmacokinetics, ADAs, or the toxicity study. This is an open label study. That means that both the volunteers and as well as the investigator, they know that what the treatment is being given. Phase 2 trial is first introduction of the drug in the patients. This is an exploratory trials done in 50 to 200 patients, and we assess the pharmacodynamics, efficacy. Dose ranging is done. That means what dose is better for the treatment of the disease condition. We study the toxicity, and then it is a single branded. That means the patient is not knowing whether which drug is being given. Phase 3 studies are multicentric trials. That means that they are conducted at many multiple centers, and this is a therapeutic trial where that means exploring the therapeutic effect of the drug, and done in a large number of patients, say around 200 to 2000 patients. We test the efficacy and the toxicity, and it is double blinded. That means both the patient as well as the investigator are not knowing which therapy we are going to give, which who is getting the control and who is getting the experimental drug. And after the phase 3 new drug application is applied over here, and then the drugs after its approval comes to the with all these data comes into the post marketing surveillance phase 4, and there is a restricted sale of the drug for the first 4 years, and it is generally done in more than thousands of 10,000s of patients, and safety data is collected. Initially, the safety data has to be submitted